Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be focusing on respiratory interventions. So if they tell you the patient is having certain symptoms or they have a certain disease, what would be the best thing to do? Remember, the right answer is the right answer because of the other answers. So you're not looking at these to say this is always the best thing. It's to say, what are my options? Out of these options, what's best? So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe, in my opinion. You can go to clinicreviews.com and find out more about our 21 plus hour Nclex review. You can get it online on demand. You can also take it in person with Mark Klimek himself. He offers the review probably 6 to 9 times a year in Ohio if you want to come to Ohio and see him in person. Let's see, what else do we do? Oh, we have a streaming service and we have small group tutoring. I do help with the small group tutoring. I do the next gen. So if you want to meet me in person, well, over Zoom, you can do that. And I can teach you how to do next gen questions. Let's go ahead and get started. We're going to focus on respiratory interventions. So if they give you some symptoms or they give you a disease and then they say, what would you do here? That's what we're going to be focusing on. Okay. A client with asthma reports nighttime coughing and wheezing. Which long-term medication should the nurse reinforce teaching about? Albuterol inhaler, Montelukast singular daily ipratropium bromide, nebulizer, prednisone taper over 5 days. All right, so we've got asthma, coughing and wheezing. Now, the key word is long-term medication, because if I want to deal with the coughing and wheezing in the immediate, I would definitely do the albuterol, okay? And then you might say, well, okay, I know prednisone's not long-term. Okay, that's short-term. That's for an acute exacerbation. So I'm going to cross off A and D. So then I've got singular and I've got ipratropium. I know ipratropium can be used long-term, but it's not ordered long-term. It's ordered PRN. And when we think about long-term management, what we want to do is prevent exacerbation. So we want to do something that's on a regular basis. And so singular is what we take. Now, if you're like, I don't know if it should be given in the evening, then don't worry about it. Is this medication a medication that's used to long-term to manage asthma? And the answer is yes. A patient admitted with acute exacerbation of COPD is anxious, restless, and confused. The ABG shows a pH of 7.3, which is acidotic, PaCO2 of 56, which is high, and a PaO2 of 78, which is just a little bit low. Which intervention should the nurse implement first? Now, just to make sure, the PaO2 is supposed to be 80 to 100, but we don't really see massive drops in saturation until it gets below 60 millimeters of mercury. So 78 is outside normal limits, but it's not low enough that I think they're probably desatting. Okay, just making that clear. All right, interventions. Apply non-invasive positive pressure ventilation, administer IV morphine for anxiety, increase supplemental oxygen 6 liters via face mask, encourage pursed lip breathing. Let me reread that. Which intervention should the nurse implement first? So first, all right, so we have COPD admitted, exacerbations. They're symptomatic COPD, anxious, restless, and confused. Anxious, restless, and confused are unexpected findings for COPD. They're not respiratory symptoms, they're neurological symptoms. So I say, why is he having neurological symptoms? So he has neurological symptoms because he's acidotic and his CO2 is high. So when I think about what do I want to do first, I want to get the CO2 down. Okay. Now the PaO2 is 78. I may want to increase the O2 6 liters. I may want to take it up to 6 liters, but that can't be first because that's not that far outside normal limits. And the restlessness and confusion is not caused by that 78 millimeters of mercury. So what can decrease CO2? Well, A can decrease CO2 and D can decrease CO2. So would I rather do a non-invasive positive pressure ventilation, which is BiPAP, or encourage pursed lip breathing? So non-invasive positive pressure ventilation, what that does, that's a mask. It's a lot like CPAP, only we use it more to decrease the work of breathing. So someone with COPD has to work to exhale. You and I, You and I have to work to inhale, but exhalation is passive. It's just the recoil of our lungs. COPD loses that lung recoil and they have to work to exhale, which is why when they're having an exacerbation, a lot of times they become very respiratory fatigued and they have trouble exhaling all their CO2. So what BiPAP does is it decreases the work of inhalation by keeping a positive end expiratory pressure so that inhalation is easier so they can use their energy to exhale. So BiPAP is actually very effective in promoting exhalation of CO2. And then pursed lip breathing is good. It's like take a breath in and then you say, keep exhaling, keeps exhaling. It elongates exhalation. The problem is pursed lip breathing is going to be difficult to teach if he's anxious, restless, and confused. So in this case, the best way to address his primary problem, his most acute problem, is BiPAP. A patient with acute pulmonary edema has pink frothy sputum, crackles throughout lung fields, and severe dyspnea. Which prescribed intervention should the nurse question? IV furosemide 80 milligrams, we'll say IV push, morphine 2 milligrams IV push, oxygen at 10 liters via non-rebreather mask, IV nitroprusside infusion. Okay, this person to me, well, they've definitely got pulmonary edema. Pulmonary edema is actually fluid in the lungs, and his sputum is pink and frothy. He's got crackles and severe dyspnea. I'm thinking heart failure is what I'm thinking. However, I don't necessarily have to know that. I just have to know that these symptoms are pulmonary and fluid in the lungs. So I definitely want to give him the furosemide. That's definitely something I want to give him. That's going to help get rid of some of this fluid. Morphine, I don't know about that. Morphine can decrease anxiety. So I don't see any, there's no reason to question that order. And remember, if you question an order, it's because you think it could harm the patient. I don't see any way morphine could harm them. So it seems okay to me. Oxygen, 10 liters via non-rebreather. He's got severe dyspnea. I don't see how 10 liters non-rebreather could harm him. It doesn't seem like too much. I don't know if it'd been my choice if I would have started him on 10 liters non-rebreather, but if he's that fluid volume overloaded and is severely dyspneic, 10 liters non-rebreather may be what he needs. So I don't see any reason to question that. IV nitroprusside. Nitroprusside decreases blood pressure. Why would I want to decrease blood pressure? Nitroprusside decrease blood pressure? That doesn't make any sense to me. Pulmonary edema decrease. If I'm looking at this, now, y'all, I know what the right answer is, okay? But I'm talking through it like if I didn't know what the right answer was. If I didn't know what the right answer was, I'm looking at this and I'm like, furosemide's good, oxygen's good. Which is more likely to harm him, morphine or nitroprusside? And I think if I'm going to really lower his blood pressure, that doesn't seem good to me. Like, why? It doesn't even say he has high blood pressure. So I don't see why I would do that. Now, IV nitroprusside ends up being the right answer. And nitroprusside, generally speaking, is reserved for hypertensive crisis. There's just no reason to do that. So the correct answer is D. A child with croup arrives with a barking cough and inspiratory stridor. Okay, it sounds really bad. It's a really narrowed airway. At rest, cough and inspiratory stridor. Which intervention should the nurse prepare? Cool mist humidification, IM epinephrine, aerosolized racemic epinephrine, or oral dexamethasone? So I like cool mist humidification. It seems like that would help. IM epinephrine, I like aerosolized racemic epinephrine better because it's going to work a lot faster at the source, right? So epinephrine decreases inflammation, and aerosolized racemic epinephrine can decrease the inflammation, and stridor is a result of airway inflammation. So I like C. Oral dexamethasone, I like that. That's also going to decrease inflammation. So which one is going to do that the fastest? Cool mist humidification, that seems like it could take a long time. It could help, but it seems like it's going to take a while. Aerosolized racemic epinephrine is going to go right to the source and decrease inflammation. Immediately. Oral dexamethasone is going to take at least an hour or 2 hours to start to decrease that swelling. So the best one here, the one that's going to work the fastest, is aerosolized racemic epinephrine. And epinephrine, just depends on how you give it, right? If you give it systemically, it's going to have systemic effects. If you give epinephrine systemically, it's going to increase blood pressure, it's going to increase heart rate, it's going to cause constipation, it's going to cause bladder retention, it's going to cause dry mouth. Like if you give it systemically, it's going to cause all that. If you give it aerosolized, it can have some of those side effects, but mostly, and certainly dry mouth would be one of the side effects you could have, but most of the systemic side effects are not going to be present when you give it aerosolized. It's going to have at the site where it touches, most of the effects are going to be there. A client with cystic fibrosis has thick secretions and frequent atelectasis. Which nursing intervention is best to mobilize secretions? Administer pulmazine inhalation, encourage diaphragmatic breathing, provide guaifenesin orally 3 times a day, teach incentive spirometry. Okay, cystic fibrosis is a disease that causes very thick and tenacious secretions, and they need to be able to get rid of those. We do a lot of positioning and pounding on the chest and trying to drain and all that kind of stuff. Atelectasis are small areas of collapsed lung. Doesn't really have anything to do with this question because they are asking about mobilizing secretions specifically. So will diaphragmatic breathing mobilize secretions? It's not a typical intervention. So I'm going to cross off the ones that aren't typical. Incentive spirometry can prevent secretions, but I don't really know that it does much to mobilize them. I mean, it does a little bit. Taking deep breaths certainly can help, but primarily incentive spirometry prevents fluid from building up in your lungs. So I don't really like D as a way to mobilize. Guaifenesin does thin secretions and allows them to be coughed up, but I don't know how helpful it would be for the thick secretions of cystic fibrosis. These are extremely thick and tenacious and difficult to mobilize. So pulmazine is a drug, Dornase alpha is a drug specifically given to those with cystic fibrosis to help thin and mobilize the secretions. And it has some effect on the underlying disease process of cystic fibrosis. I don't have the pharmacology right off the top of my head, but it is specific to cystic fibrosis. So what I'm saying is that you don't have to know everything about everything, but you have to have some familiarity with things. So when you get a question like this, because remember, this is primarily an Nclex prep channel. I'm not teaching you how to be a nurse. If you're a pediatric nurse and you work with cystic fibrosis patients, you're going to have to know all about pulmazine, okay? But that's not what the purpose of this channel is. The purpose of this channel is to teach you how to think clinically and using common sense to answer questions. So instead of saying, okay, you have to know everything about pulmazine, you need to say, I need to know a little something about cystic fibrosis, and I need to be familiar with the drugs that are used to treat cystic fibrosis so that I can at least recognize them and know when they're appropriate to be used. A patient with tuberculosis is on isoniazid and rifampin, which lab should the nurse monitor regularly? Serum creatinine, liver function, platelets, serum potassium. So I know that isoniazid and rifampin affect either the kidneys or the liver, and I just have this thought in my head where I go, I'm pretty sure it's the liver. So what you need to know, you should know isoniazid and rifampin are used to treat TB. Those are the drugs that are used. They should be taken for a minimum of 6 months if someone's diagnosed with TB, sometimes up to a year, depending. You should also know that they are required to take them. So sometimes we can even do supervised having people take them under supervision if we don't think they're going to take them regularly. Like if a homeless person has TB, they actually have to go to the health department every day to take their meds so that we can see them taking their meds. And we have to monitor liver function. So that's what you should know about those drugs. A patient with pleural effusion has decreased breath sounds on the right lower lobe and dyspnea. Which intervention should the nurse anticipate? Administration of furosemide, thoracentesis at the bedside, encouraging deep breathing exercises, or chest physiotherapy. So you need to know the difference between pleural effusion, pulmonary edema, and atelectasis. Pleural effusion is actually fluid in the pleural space. The pleural space is the space between the lung and the chest wall. Pulmonary edema is fluid in the lungs, and atelectasis is small areas of the lung collapsing. And that's what those words mean. So you need to be able to interpret the question based on the vocabulary. As long as I've known Mark Klimek, he's always said vocabulary is the number one reason people fail Nclex. So pleural effusion is fluid in the pleural space, which means chest physiotherapy and deep breathing exercises are not necessarily going to help with that. Furosemide is not going to help with that. Thoracentesis, that's where you actually put a needle in the pleural space and you pull fluid out. So that's what thoracentesis is, needle into the pleural space, pull the fluid out. Hopefully the fluid doesn't come back, depending on why they've had a pleural effusion. Sometimes it does come back, but most of the time we'll treat it, and then we can maybe give them an antibiotic or something else that they may need to help keep that off if they're sick or whatever the problem is. A client with acute bronchitis has a productive cough and low-grade fever. Which instruction should the nurse emphasize? Use antibiotics until the sputum clears, increase oral fluid intake, restrict activity to promote rest, take cough suppressants at bedtime. All right, bronchitis is a disease that increases the secretions in the lungs, so you kind of have this chronic cough. And most of the time, not always, but most of the time, bronchitis is actually caused by a virus. Now, if it had said acute bacterial bronchitis, if it said acute bacterial bronchitis, I'd say we need antibiotics. But they didn't say that. And they said low-grade fever. Low-grade fever makes me think it's viral. And viral means we have to just encourage them to do the things a person does when they're sick to get better, right? We're not going to do antibiotics. Now, A would be wrong anyway, because you would tell them to take their antibiotics, to take the full course, even if they're feeling better. You don't ever tell someone to take antibiotics until sputum clears. So A is just wrong, just in the way it's written. But what you do when someone has a viral infection, you say, how can we promote them getting better without medication? Like, you can give medication for the low-grade fever. They could take Tylenol, but that kind of thing, right? So this is really a common sense question. It really is. It sounds complicated, but it's not. It's, what do you recommend to someone who's sick, but they're not going to get an antibiotic? So I'm going to cross off A. Do we tell them to increase oral fluid intake? Well, yeah, we want people to stay hydrated. In fact, that's pretty common what we say, stay hydrated. That's going to thin those secretions out, and you're going to be able to cough them up better. Restrict activity to promote rest. I don't mind them getting rest, but I don't really want to say restrict activity. I don't know. I just don't love the way C is written. It's just weird. It's just weird the way it's written. It's not the worst thing you could do, but I don't love it. Take cough suppressant at bedtime. Well, they could take a cough suppressant. They can, and maybe it would help them sleep a little bit. But what is the best thing? All right. Would I rather tell them to increase oral fluid intake or rest? So I'm going to tell them to rest, but not increase oral fluid intake. Well, this is a lung problem with secretions. We've got to mobilize these secretions. So honestly, I'd rather tell them to increase their oral fluid intake. Would I rather tell them to increase their oral fluid intake or take cough suppressants at bedtime? So take cough suppressants at bedtime, but don't increase oral fluid intake, or increase oral fluid intake, but don't take cough suppressants at bedtime. I really like the oral fluid intake. And this is just a common sense question. This is why I say, do not throw your common sense out the window. You have to think in general. What do I tell people who are sick? They've got a low-grade fever. They don't feel well. They've got a cough, right? This happens all the time to us, all the time. We get sick like this. Our friends get sick like this. Our patients get sick like this. What do we do? Teach them to help them get better. A patient with severe pneumonia is confused and hypotensive. So those are unexpected findings. We don't expect someone with severe pneumonia to be confused and hypotensive. Which findings should the nurse address first? White blood cell count of 18,000. Well, I don't know if it's bacterial pneumonia, but if it is bacterial pneumonia, 18,000 would be an expected finding. Blood pressure of 80/50, that's unexpected. I don't expect that. A temperature of 101.8, that would be expected if it's a bacterial pneumonia. O2 sat 92% on 2 liters. I don't know what to do about that. I'm going to keep him there. I wouldn't really do anything about that. So the only unexpected finding here is the blood pressure of 80/50. So that's the one that I have to address. A patient who smokes 2 packs a day presents with barrel chest, dyspnea, and decreased tactile fremitus. Tactile fremitus is when you put your hand on the chest and they talk and you can feel them talking. So a barrel chest decreases tactile fremitus because it has to go through more air space, and it does decrease tactile fremitus. Which condition does the nurse suspect? Pneumonia, emphysema, pulmonary edema, atelectasis. Well, what causes, if you don't know any of the others, what causes barrel chest? Well, emphysema causes barrel chest. Do any of the others cause barrel chest? No. What causes dyspnea? Well, they all can cause dyspnea. What can cause decreased tactile fremitus? Probably atelectasis could a little bit, probably, but emphysema for sure. The only one out of these 4 that can cause all 3 of these symptoms is emphysema. Okay, so that's that. That was short. Well, probably wasn't that short, but what I was doing was going through questions to talk to you about choosing interventions. Y'all, there's only so many pulmonary interventions that no matter the disease, there's only so many pulmonary interventions. So it's not really that hard to know what they all are. We have albuterol, so we have bronchodilators like albuterol. We have corticosteroids, which decreases inflammation. We have antibiotics, which treat bacterial infections. We have positioning, which is always good. We have, we can intubate somebody. That only occurs when they're in respiratory failure. You know they're in respiratory failure if the CO2 is in the 60s and this PA CO2 is in the 60s and the PaO2 is in the 60s. So the PaO2 has to be low. The PaCO2 has to be really high. So we can do that. We can do BiPAP. We can do CPAP. I'm sure there's coughing and deep breathing is really good. So there's only so many interventions, non-pharmacological, increase oral secretions that mobilizes fluids. So in general, when you get a question about what should you do, think generally, use your common sense, and think, what is this question really asking me? What's the primary problem here? And I'm going to pick the answer that addresses the primary problem that they're telling me that my patient has. All right. Good luck. Thanks for being a part of the Clinic Review family.